Good evening, everyone. Thanks so much for being here with us. This is your Take Pride in Your Health event. We're here at the Metro Public Health Department to answer your questions that are health related, geared towards, of course, the LGBTQ community. My name's Josh Breslow. I'm with News 2, and I'm joined here by a panel of experts with far better credentials than I have. They're here to answer all your health-related questions. And before we have them introduce themselves, we do want to tell you how you can submit those questions, because we do want to hear from you and answer those questions that you have. You can send your questions over to takeprideInYourHealth@nashville.gov. That email address, takeprideInYourHealth@nashville.gov. We don't have to use your name, so if you do want to ask an anonymous question, that is up to you. All right, up first, I do want to have you guys all introduce yourselves. Thanks so much for being here. We'll go down the line.
Thank you all for having me. My name is Brian Marshall. I am the CEO and founder of Mashup Nashville, which is an organization that addresses health disparities and social inequalities for Black, gay males, and trans women of color.
My name is Christine Fouch. I'm a registered nurse here at Metro Health Department. I work at the Sexual Health Clinic, and I've been a member of the gay community for a while now. I'm a lesbian and identify as that.
Hi, my name is Adrienne Good, and I work here at the Health Department in the Sexual Health Clinic as well. I've been in HIV STD for over 20 years now.
Hi, I'm Rajiv Malvath. I'm the director for the Ryan White Part A program here. My background is that I'm a physician and as well as an epidemiologist, and I've been working with the HIV, STD, and hepatitis program, or working with those viruses for quite some time.
And I'm Dr. Sean Kelly. I'm the Associate Medical Director of the Comprehensive Care Clinic at Vanderbilt. We have a patient population of about 4,000 people living with HIV that we care for in Nashville and Middle Tennessee.
All right. Thank you guys so much for being here. We appreciate it. And we do have a few questions that have already come in, so we're going to go through those first. But make sure if you do have a question out there that you submit it right now. Take pride in your health@nashville.gov. Up first, the first question here, why is it important to include health as a part of the conversation during Pride Month? Of course, right now it is Pride Month.
Well, I think it's important to have the conversation every month. People are not just having sex during Pride Month, but since, this is a month where we have a lot of people's attention, it's a great time for us to engage the community, just to remind people that it's important to take care of your sexual health. We have COVID-19 that's happening right now, and, there are a lot of important conversations that we need to have around COVID-19, but I'm kind of hearing less and less conversation about sexual health, and people are still having sex. So I think that now that we have everybody's attention, this is a great time to re-engage our community.
And especially our teenagers. All the community, we want to come in, we want everybody to get tested, but a lot of times the teens are apprehensive with testing. And the message we want to get across is that it's completely confidential. And we're advocates for you. We're here for your health.
Anyone else want to?
I'll jump in as well. As far as like the health component, it's not just about, even though I work with HIV and we deal with STDs and some of the others, but it's also just the general health of the population. We have an aging population, at least in our group of more than 50% who are 50 years or older in our HIV community. So we're looking now at the long-term health of those people. Diabetes, heart disease. We're treating HIV like a chronic disease, and we now have to worry about the other chronic diseases that people have to deal with, and that includes those diseases. So I think it's very, very important, not just concentrating on the infectious, but also those other diseases that can cause morbidity.
And I think this is a good time now to kind of take a step back and remember what's important. Because what was important was very different 3 months ago. Over the past 3 months, every single thing that we did, health was at the forefront of our minds, whether it be going to the grocery store, leaving our house without a mask, trying to find toilet paper or hand sanitizer in the grocery store. And because of that, that sort of overshadowed the other important aspects of our health, chronic medical conditions that we live with, or sexual health. that we may have had to forego these conversations because of the risks associated with leaving our house to talk to a doctor or to get tested. Now is a great time to get back into talking about that, now that we have gotten a better handle on this coronavirus pandemic, but also realize that we really can't put off taking care of our chronic health conditions and sexual health much longer.
And speaking of COVID-19, this is actually a question that we've gotten a few times here. How has COVID-19, if at all, impacted PrEP services or other clinical services?
So in addition to being the Associate Medical Director of the Comprehensive Care Clinic, I'm also the Director of our PrEP program at Vanderbilt and Director of PrEP Education through the AIDS Education and Training Center throughout the Southeast. And so we have a pretty robust PrEP program at Vanderbilt with about 200 PrEP patients, most of which I know personally. And it was a big challenge to deliver PrEP services at the beginning of the pandemic. In the first 8 to 10 weeks during the pandemic, because of the risks associated with leaving a house or coming to a clinic or going to a lab to get the basics of PrEP services. So the challenge was, I think, frustrating and just seemed like it was unnatural as a doctor to not being able to provide the standard of care because the risks of the pandemic outweighed the risks of delaying labs or missing a PrEP visit. So what we ended up doing was having a lot of conversations. Many patients of mine I knew very well, and I knew that they were adherent, and I knew that they were stable and tolerating the Truvada or the Descovy very well. And so in those cases, I thought it was much safer to say, okay, stay home. Don't come to clinic. We'll defer your visit for another 2 to 3 months. We'll hold off on labs until it's safer to do so. Of course, there were patients that needed to be seen. They had a symptomatic STI, needed to get tested, whose adherence wasn't really well known. That's when telemedicine sort of came into the picture. It was really incredible how quickly Vanderbilt and other major medical centers pivoted to develop these and rapidly develop these telemedicine platforms when previously telemedicine was not a huge part of how we delivered care. But we were able to do that pretty quickly. And then another unique factor, and sorry to monopolize this question, y'all, but another unique factor with Nashville itself is that Vanderbilt developed its own coronavirus test right away in mid-March, right after the first case was reported, which served as our testing capacity for quite a while. And so, as you could imagine, the resources really had to be directed toward coronavirus testing, which was really life or death. You know, we really needed to get coronavirus tests processed quickly and robustly. And as a result, lab resources were pulled toward coronavirus testing and more away from STI testing, from GC chlamydia, which actually was the same part of the lab. As a result, we just couldn't do tri-compartment testing. We couldn't do walk-in urine GC chlamydia testing simply because the resources just weren't available because of the pandemic. And it took a lot of planning and a lot of willpower and changes in the structure of our lab to be able to coordinate getting standard STI testing back as part of our standard of care, which we're able to do now.
And I can jump in as far as like some of the other services as well. I do want to give a shout out to our sexual health clinic here, who does have PrEP services, so I'll defer to Christine for that. But as Sean had mentioned, we had to start thinking outside the box. There was a lot of conversations about like we can't do the same things that we do on a day-to-day basis before COVID. Telehealth was a big part of that, and for many of our HIV support service organizations, many of their staff were working remotely, or they still had to provide services, but they had a higher mortality, a population with higher morbidities, or they were an older population. So again, those were the risk factor groups that had to avoid traveling or coming out into the community. So a lot of the telehealth really expanded during that time. The other thing that I think we also benefited from was also the CARES Act. There was we received almost $1 million for the Ryan White program to assist for clients who are HIV positive and affected by the COVID-19 disease. So that actually helped us with providing some additional funds for like emergency financial assistance, rent assistance, food, um, and just even like getting supplies, personal protective equipment for our clients as well as our agencies, and some changes to the structure of the agencies so you could have social distancing. So those were some of the things that COVID-19 has done for our side, but definitely it's affected the PrEP side. So if Christine wants to say anything about how it's affected you guys.
What I was going to add is that here in the clinic, we couldn't do the Zoom or the telehealth. And what we did was, instead of a walk-in clinic, now you have to call and make an appointment. And we've staggered the patients out, so we don't have a lobby full of patients. And we never closed. We're still here. We're still, testing, and we will be here. The biggest thing is make an appointment, and we will get you in, and you will be tested. If there's been any high-risk activity, we're still testing for chlamydia, gonorrhea, HIV, syphilis, herpes, the 3-compartment testing as well. And when a lot of patients come in, they say, and they didn't realize how unjudgmental we are. They're like, this is really nice. I was so scared. I was so apprehensive about coming in. And so now we have regular patients that come back, and sometimes we're actually cheaper than going to your private doctor. So we have some patients that actually have insurance, but they prefer to come to us, where it is just $10 for a whole screening. And that does include medicine if you need it. And so that's the biggest thing. I think a lot of people just don't know we're here, we're available.
And are you still seeing a lot of people that are showing up?
Yes.
All right. And how would you describe the state of LGBTQ health here in Nashville?
Okay. Well, I do think that there's a lot of great work that's happening. We have a lot of great organizations that are addressing the needs. I serve on the Ryan Wright Planning Council, and so I know that we are doing a lot of great work to ensure that services continue for underserved populations. I will say that we still need to take a look at the numbers, look at the statistics, and understand why people of color, primarily African Americans, are still at the top of the list. And so, although there is great work that's being done, I think we have to dive a little deeper and understand why Black gay males at the top, why our trans women sit at the top, and even Black women who may be lesbians, why they sit at the top of the list. And so I've been doing a lot of research. I'm currently working on my doctorate in education at Trevecca, and so I've just been reading a lot lately. And one of the things that I see other states looking into is kind of looking at racism as a public health crisis. And I know that's kind of an uncomfortable conversation to have, but I think that in this day and time, we have to have that conversation, because we're not just talking about sexual health. We're looking at homelessness, other social determinants of health, employment, just health equality barriers, education. And so there needs to be a robust conversation here in the city of Nashville. I think it's had, but I think more conversation should transpire.
Necessarily see that side of it, but I'm in the surveillance department, and also being in the field, I would say that I would like to encourage the community to trust us more. And so like he said, we can have those more open conversations. Racism does have a lot to do with it, because you'd be surprised at how many of our clients will say, well, what about Tuskegee experiment? Are you going to inject us with this? Are you going to give us this? Are those tests valid? So I think it is a part of bringing the communities together and understanding what our purpose and our goal is, and it's to help, not to hinder. And we want a better environment for everyone, So, like you said, that is very true. We have a lot of just anxiety and caution when it comes from some of the underserved communities when it comes to the health department. And we just want to get the message out that we are definitely here to help and provide services and encourage the sexual health. We don't want to present this us against them type of relationship. So he's right. I think there's a lot of programs in place, but we still have a long way to go.
And if I can just add, I think that it's so important for organizations, institutions, to really get out in the community. A lot of times we look for the community to come to us, but we need to get out in the community more. Actually, I attended Tuskegee University, and the first class that we took talked about the syphilis study. And so me coming into the health field and understanding the importance of research and understanding the importance of, clinical trials, I still was hesitant. And because I was a voice for the community, I actually got involved with the Vanderbilt Vaccine Trials Unit, and they are doing an amazing job. But I got in touch with them because they got out into the community and built those meaningful relationships, with me, because even though I work in the field, I'm still a part of the community. And by building that meaningful relationship, it helped me understand and get more comfortable with being involved in adding to research and, so I can, better, educate myself, so I can better educate other people. But I mean, in essence, we have to get out in the community. We have to know where those vulnerable populations are. We have to know who they are, even by name, by face, and educate them and make them aware of the services that we have available.
You're 100% right. I think with so many other social issues that are impacting people, like food equity, all kind of things, they're not really. When you are not eating or have nowhere to sleep, then you're not worried about a little discharge. If we're going to bluntly speak, you're not worried about, oh, I may be exposed to HIV or I may be exposed to some other STD. Your primary goal is to live, is to eat, sleep, try to have some type of mental stability, and that's just not what's important to them or what's on their priority list. So you're right, we do need to get out there so that they know we're there for them instead of expecting them to always be in a position to present that to us. You're right, that's a good point.
I am grateful for, all the work that we're doing, and I worked on the ETE plan initially, and Miss Julia, she invited me to be back on the ETE task force, and so we're continuing to have that conversation, continue to come up with, different ways that we can improve services. And so I would say the state of Nashville is we're still doing work, there's just more work to be done. Yeah.
Because we see the different populations, and I'm happy to say also that Brian is the chair of the Needs Assessment Committee as part of our Planning Council, so he looks directly at the data that we get to see which are the populations that are most at risk and affected by the HIV, at least with Ryan White. But there's also a population of the Latino population that also needs to be highlighted. We are seeing an increased disease burden, at least for HIV, with that population. But I'll step back a little bit, and I would say messaging is one of the most important things for the entire LGBTQI community. We have to learn how to speak better in a language that is going to be acceptable to each member of that community. What do I mean by that? When you talk about the LGBTQI population, you're not talking about some monolith, one piece. These are actually different communities within kind of like an umbrella term. And what may work for one particular community may not necessarily work for somebody else. Even the way you actually send the information. If you happen to be someone who's younger, you have to look more along the lines of social media. And it's not necessarily Facebook. You may have to go to Twitter. You may have to go to Instagram or whatnot. The Latino population we've heard is they tend to prefer a little bit more of the traditional media, radio, newspaper, television, that sort of thing. Even the terms that we use, for example, the phrase queer, for an older member of the LGBTQ community, that is actually considered like a derogatory term, but it may be accepted. Some of the younger population may say we are genderqueer. So even so you have to be very, very mindful about how you go about just communicating with these various groups. And the only way we can do that is we really need to be able to immerse ourselves with the community. As Brian mentioned, we have to go out, and as Adrian said, we have to be able to ensure that there is trust. And that's actually what's going to help in the long term is how we communicate with with the varied groups, and they understand that we speak their language and they understand our concerns.
And going back a couple questions here, I actually didn't even think to ask this, but someone wrote into us and said, talk to us about PrEP and exactly what it is, because I guess, there are a lot of people who have never heard of it and don't know what it is.
Thanks for whoever asked that question. PrEP is, I think of PrEP as a program. So it's an acronym, Preexposure Prophylaxis for HIV. It's a program because it's not just HIV prevention, it's comprehensive sexual health care. So the HIV prevention aspect is met by a pill. So that pill is actually, there's two options now. One of them is called Truvada. It is a single pill, contains 2 medications that are active against HIV. It's actually been around since 2004, but we didn't know it worked very well for HIV prevention until about 2012 when the FDA approval came. So it's been around for a while now. It's been around for over 8 years. One pill once a day, taken every day, can prevent HIV over 99% of the time. So the most effective thing we've ever had. It is going to be the instrumental thing that ends our HIV epidemic with treatment as prevention along with it. So we need to use it more robustly. Little story, I moved down from Chicago in 2016, and at the time in Chicago, PrEP was on the sides of buses. I mean, it was on billboards. Everybody knew what PrEP was. It was part of the standard of primary care. You know, primary care doctors provided it. Walk-in clinics provided it. I came down to Nashville, very few people knew what it was, and very few providers actually prescribed it. And that blew me away. And that was the start of our PrEP program back in 2016. Since then, though, we've been able to educate providers all throughout the South, and there have been PrEP providers, even in 2018, that surpassed our PrEP prescriptions at Vanderbilt. And now there are PrEP providers in Nashville that have surpassed us tenfold. So just by educating our community, and our providers and talking about why this is important and how easy it is, we've seen a huge PrEP uptake just over the past 4 or 5 years here in Nashville. I mentioned there are 2 pills, so Truvada is one of them. The other one is called Descovy. It's virtually the same thing, the same medications more or less. One of them is a different formulation with theoretically lower risk of bone mineral density loss and loss of kidney function, but overall both of them are extremely safe. Safer than most medications we use for something like blood pressure control or diabetes control. These are medications that should be talked about during almost every primary care discussion, and it's starting to look like that's happening more in Nashville than it was before. Both of these are extremely well tolerated, very affordable. All insurance plans in the United States cover Truvada with variable copays. Descovy, because it's fairly new, about half of insurance plans cover it right now. But the drug company has programs that will cover copays, so most people pay nothing for it. The drug company actually donated a ton of product. I think there was enough product for 250 million people per year for the next 10 years. And there is a federal program as part of the federal Ending the Epidemic program where if somebody has no prescription coverage, is HIV negative, and has a prescription for either Truvada or Descovy, they just apply for it online and they've got it for free. There are other centers here in Nashville, including here, for $10 a visit. You have a PrEP navigator here. Can get a patient signed up for these copay assistance or medication access programs for free medication. So in summary, it's one of our best tools for HIV prevention that we've ever had. We need to use it more. Start talking to your doctors about it more. Start talking to your friends about it more. Ask more people about it. It needs to be normal. It needs to be a normalized part of our life and our healthcare. And we'll get there. I think we will. Just seeing how phenomenally we've done just over the past few years here in Nashville.
And like you said, we have a PrEP clinic here as well. It's a sexual health clinic, and we offer it to every single patient that comes in. And automatically they're tested every 3 months, so you're covered in all aspects. It's a wonderful, wonderful program.
And I just also want to let the folks know that Music City PrEP has also a program that provides that service. I just want to, I'm always the guy who needs to throw water on the fire, but I want to reiterate what Sean just mentioned, was that it's HIV prevention. It does not do anything for the other sexually transmitted infections or hepatitis or whatnot. So we still say use the barrier methods like condoms and lube and so on, and to prevent those other infections. PrEP is primarily for HIV prevention.
And being a recipient of PrEP, so taking PrEP every day, it really does require some testing. The most important being HIV testing to make sure you remain HIV negative on it, but also screening and prevention and treatment of other sexually transmitted infections. And so typically we'll see PrEP patients in clinic out pre-pandemic times every 3 months. And we would do HIV testing, tri-compartment gonorrhea, chlamydia testing, and then syphilis testing. And I think that PrEP is going to be the biggest and most important tool for reducing our gonorrhea, chlamydia, and syphilis rates, because never before have we really had a captive audience, coming to clinic every 3 months, getting asymptomatic screening, getting treated for asymptomatic infections, and therefore removing it from the community. So PrEP, I think, is just going to be, a phenomenal strategy for lowering our already skyrocketing gonorrhea, chlamydia, and syphilis rates.
And thank you to all the viewers who have sent in questions here. We appreciate it. You can still send your questions over to Take Pride in Your Health at Nashville.gov or on our Facebook Live video, wherever you want to, but make sure to submit those questions. We've got a few of them already here, and one that a lot of you guys, I'm sure, can weigh in on here. What question do you hear most about sexual health, and what is the biggest misconception?
I think the biggest misconception is that you can look at someone and tell that they have an STD, or that you can figure it out by some magical test. You hear all kind of ways that people test themselves or their partners for STDs that aren't really valid. So I think that's the biggest misconception, is that you can pick someone out and know that they are clean or unclean or infected or not just because of the way they look or present themselves. STDs doesn't matter if you're rich, poor, black, white, gay, cis, whatever. You cannot really pigeonhole one group of people and say, oh yeah, I know that they're going to be more susceptible to that than others. So I think that's the biggest thing. You hear people just saying, oh, they look clean, or I didn't think, So I think that was the biggest thing, especially in the teen community. They feel like they're, just above everything and they're going to live forever, so they don't really think about those things.
I totally agree with you. I think that when it comes to the patients I care for, the big misconception is that if I have a sexually transmitted infection, I'm going to have symptoms. And so if I don't have symptoms, therefore, I don't need to get tested, I don't need to go to the doctor, I don't need to do anything. The reality is that more STIs, I think, are asymptomatic than we previously thought. I diagnosed a lot of rectal gonorrhea, chlamydia and throat gonorrhea, chlamydia, and I can't even remember the last time either one of those was symptomatic, which is the most dangerous type of infection, an asymptomatic infection, because not knowing you have it, you can easily transmit it. And so I think I have to educate patients every single time that, remember, even if you have no symptoms, if you got exposed, you got to let me know right away so we can treat you. Or if you had any potential exposure, let me know so that we can treat you.
I ran into that situation just yesterday, and I had a female patient that kept returning. She kept testing positive for chlamydia. Her boyfriend wouldn't get tested because he wasn't having symptoms. So and I said, well, you're going to keep coming back. We're going to have to keep retreating you unless he comes in and gets treated. And then you got to consider, if the person has other partners, you need all the partners treated, or you're going to keep getting re-exposed.
Yeah, for sure.
I think, I don't know if it's a misconception, but I definitely think this is a lack of education and understanding undetectable status. And so, when somebody says, I'm undetectable, there's individuals who still believe that you can transmit the virus when you are undetectable. And so I think there needs to be more education, Doctor, just explaining and helping people better understand what undetectable actually really means. And actually, if you could just kind of dive into that a little more on the medical side.
For sure. This is sort of a new concept. We're learning this recently, over the last few years at least. So undetectable equals untransmissible. Let's talk about what undetectable means. So if somebody's living with HIV and they're not on any treatment whatsoever, they get a blood test, we're able to actually detect the virus. We can find the virus, and we can count the number of virus particles within about a milliliter of blood. That's what we call a viral load. That number can range between a few hundred to a few million. Everybody's a little bit different depending on the stage of infection, their own genetics, their own immune system. But if we can find that virus and count them, that person is detectable. Now, we have great medications, the best we've really ever had, super potent, very, very effective. Virtually all HIV infections can be treated to the point that we can't find the virus in somebody's blood anymore. Once we can't find that virus, in other words, we can't detect it, they're undetectable. And the level that we can't find it, it is variable depending on the lab that we use. Typically what we'll consider throughout the world, because of what the technology is throughout the world, below 200, most countries will consider that undetectable. Here in the United States, below 40 or below 20, depending on the lab, we'll consider undetectable. For all intents and purposes, though, all the big studies that looked at undetectable participants used the 200 cutoff. So let's just say 200 is undetectable for the sake of this talk. There were 4 big studies over the past few years looking at serodiscordant couples. So one living with HIV, one HIV negative, where the one living with HIV was on treatment and undetectable. Now, these couples were followed within these 4 studies for a long period of time and collectively represented over 100,000 acts of condomless sex. And among all those couples with all of that sex, there were 0 transmissions. Enough to tell us that if you are on effective HIV treatment, if you are undetectable, you cannot transmit the virus. And that's what that means. Undetectable equals untransmissible.
And so I think what happens is we need to also have clarity on when somebody is undetectable, why they still have to be classified as HIV positive. And so I think that's what's maybe throwing a lot of people off, because they're saying, well, if you're undetectable and you can't transmit the virus to me, then why is this person still classified as HIV positive?
And that's really because we don't have a cure for HIV yet. And I hope one day that's not going to be the case, that if somebody is undetectable and eventually cured, they won't be HIV positive anymore. But right now, HIV is a chronic infection that we cannot fully get rid of. So the medication will treat it to the point that it's no longer in somebody's blood, but it will be sticking around in some immune cells throughout our body. We call them reservoirs, just kind of sleeping. You know, it's not really doing anything because the medication is keeping it so suppressed that it can't really do anything. But if somebody were to come off medications, the virus that's sort of sleeping in those reservoirs could potentially wake up, and then they'd become undetectable again. There have been a couple cases in the history of our world where we've seen cure of HIV infection, but that's required a full wipeout of somebody's immune system in a stem cell transplant or a bone marrow transplant, something that's really not feasible for most people living with HIV. So until we have a cure, we can treat HIV to undetectable, but those people will still be considered HIV positive.
The misconception is that, actually there were 3 of them that I'd like to mention. First one is, I still hear, well, HIV is a gay person's disease, you know? And that's not true. It is a blood-borne disease that if you are, let me step back. It's based on contact with infected bodily fluids. It could be blood, it could be semen, it could be breast milk. Yeah, thank you. These are ways in which you could potentially get HIV. So, and I point that out because just a few years ago, we had this outbreak of HIV in a place called Scott County in Indiana, where it was actually a population that was having that intravenous drug use, and they were sharing needles, and as a result, you had a whole population that was infected by HIV. In the past, you did have to worry about blood transfusions. Now it is the blood is tested quite a bit, and the program that we're named after, Ryan White, he was a hemophiliac, and unfortunately he needed blood transfusions on a regular basis, and he got HIV as a result of tainted blood. But of course, that is minuscule, and if it ever happens, you will see like a large investigation of why that happened. But now it's like we're also, I was reading an article where they were looking at potentially using HIV positive organs from one person to another person who was HIV positive, or hepatitis, you know? So it's like, it's kind of like changed. So it's not that it's like you could just classify. I remember it was like, the H's, hemophilia, homosexual, Haitian, that was kind of like the population that, but that's not the case, in Africa, it was more heterosexual transmission, which was feeding the virus. So I want to make sure that we do make that distinction, and that's part of the stigma that we need to get rid of. That this is not just because of some sort of lifestyle; it is because you came into contact with a certain type of infected fluid. So that's one thing. The second thing I want to bring up here is when people hear sexual health, they automatically think about the first three letters, sex. And that's not what this is all about. Just as we have names for different organ systems like cardiovascular, urological, pulmonary, sexual is also another part. A woman coming in to see her gynecologist on her annual visit, that's a sexual health visit. A young woman who is having some issues when she first starts her menstrual cycle and she needs some additional treatment, that's sexual health. A woman is pregnant, that's sexual health. So there's breast checks, that's sexual health. There's a lot of things that come into that particular category, and we want to make sure that when we say sexual health, it is not just because you happen to have sex. No, there's a lot of things. My own personal feeling is I wish there was a male equivalent of a gynecologist, because I think men need it just as much as women do, like getting their prostates checked, and just as they age, a number of issues that rise up because of that. So that's a second preconception that I think we want to get rid of. And the last one is actually towards ourselves, our profession. If you're going to ask about water, air, or at least the way the doctor said it is, we ask people about if they're drinking properly, eating properly, sleeping properly. One of the other basic requirements is actually sex, and physicians and surgeons are not doing that. They're not comfortable in asking those kind of questions, and I think that is very, very important. That is part of like a history that's taken, and it's not to embarrass anybody. You would be surprised the number of times when you ask a question and it's like, Doc, I've been thinking about that, but I was kind of like ashamed to ask that question. Or, oh, Doc, I never thought about that, and it's like it can open up conversations, which right now, unfortunately, we're just not doing, and I think it's very, very important. So those three things are misconceptions I think we need to get rid of.
All right, another question from a viewer here. What stigma still exists around LGBTQ sexual health? I know we've kind of touched on that a little bit, but what stigma still exists?
Well, I think that we know that homophobia still exists, transphobia. We still stigmatize sex work. Looking at youth homelessness and people who we have a lot of youth who are still homeless in our streets who don't have stable housing, and we understand, or some of us understand, that they may engage in sex work to survive. We call it survival sex. And of course, survival sex may put them at higher risk for HIV and other STDs and STIs, which is why we need more resources. But we have a lot of people who look down on them for simply trying to survive in a place where they may not have the resources to do better, or have the means to have stable housing, have the means to have food to eat from day to day, and so they turn to have sex or engage in sexual activities just so they can have somewhere to sleep at night. And so we have to stop stigmatizing those individuals, our trans women who are still, some are still afraid to come out the house or to dress the way they want to dress on a regular basis. And so they will, wear, I guess, clothes from their cis assignment so they won't have to be harassed for walking down the street. And so, I think a lot about the stigma that parents have between their children. I think that we need more resources for our parents to help understand the sexual health of the young people. I think that there are some parents who still think that their children are not having sex. But I had the pleasure of working with high school students, identifying the LGBTQ students here in the city of Nashville. And I know they were having sex on a regular basis. But I was so glad that I was able to, in a non-judgment way, have those conversations. But we need the parents to be able to have those conversations. So I'm personally looking into trying to build more programs around how do we train our parents to be comfortable and understand and move past their biases and their prejudices against their child. We need more programs for our parents. That's ultimately what I think needs to happen here in Nashville.
I've
Anybody
spoke
else?
with parents, and they will, if my daughter is not having sex, my son is not having sex, and when we see a patient, we bring the patient back alone. I've had parents get mad at me because they can't come back. Well, that's my child. Well, I'm 51 years old, and if my mother was sitting in the same room with me, I would probably lie about who I was having sex with. But once we get them back there and we tell them, it's completely confidential, then, they tell us who they're having sex with and how they're having sex and where they need to be tested. So that's the biggest thing. It's just, sometimes you can't talk to your parents, and it is, I'm just going to say it, this is the Bible Belt. There's still a lot of judgment out there. So they're going to go wherever they're accepted, and that's the biggest thing, is just to open that dialogue and let your child know that, that you love them unconditionally.
Yeah, and I want to go a step further. I think that we need to figure out how to implement improved conversations in the school system. When I did work with the high school students, I was blessed. I won't name specific high schools, but there were certain principals and parents who were okay with me having those conversations because they didn't know. They allowed me to come into the schools and, in a separate space, in a safe space, have those conversations with those young people. But there needs to, it shouldn't be something that's hidden. It shouldn't be something that I have to come hide into a private room, into the school, to have a conversation about that. That needs to be something across the board in our public school system, that it's okay for us to have sexual health conversations with our young people, because our young people are contracting the HIV virus as well, at some higher rates than the older population. And so if that's the case, then we must be missing the mark, and we have to close that gap.
Right, it's time out. People being afraid of what they don't understand. Just to piggyback on what you were saying, I have a friend that is trans, and she's lived her whole life basically in fear from what people just don't understand, or like she's even felt uncomfortable because people have, complained about her using the women's restroom. Or, is she gonna hurt me? She's not interested in you. She's trying to live her life and, just go about her business as everybody else. But we're afraid, and I'll say myself too, because we all, whatever the situation may be, we may be afraid because we don't really understand. But it's 2020. We have to stop sticking our head in the sand and educate ourselves so that we can understand basically what the situations are, so that when our children have these questions or come to us and tell us maybe that they're bi or gay, that we understand and we don't see that as a curse or something to be ashamed of.
And I just wanted to also say, it seems like if you identify yourself in the LGBTQI group, it's automatically you are more at risk for multiple types of diseases or life circumstances. And that's something that we've found in Ryan White, is that getting our clients to Dr. Kelly or to Christine for PrEP, that's the easy part. It's the rest of the things that are actually that we have more difficulty finding proper housing, being able to get behavioral health services. Maybe they need substance use treatment. So these are some of the things that are actually that we deal with on a day-to-day basis, which isn't the treatment side. That is super easy. We can get people to the doctor, finding folks. Adrian, in the surveillance side, she gets the labs from various sources, and she's providing it to our field workers to go and find some of these folks. And because of the stigma, because of just the past history of how they have been, and this is not just Tuskegee, this is also right now where the receptionist at an office may not have treated that particular patient well, even though the doctor is extremely good, with that particular patient. So that kind of like disenfranchises that group. And I think we have to be more mindful of the actual circumstance. If we, we should look at it as, oh, there are children who are at risk for being homeless or unstably housed. They may be more prone to substance use. They may be more prone to behavioral health issues, depression, committing suicide. They may be more prone to being enduring violence, partner violence, or community violence. There's just so many different things. If we say that, oh, there are children who are being affected by that, you would know what the uproar is because of that, But you have all of those, and oh, by the way, there are kids, and they just happen to be LGBTQI. So that's something I think we need to be mindful about, is the fact that these are conditions that this community is facing, and we need to do a better job of being able to walk in their shoes.
All right, so believe it or not, it's already been about an hour. So any final thoughts before we wrap up here?
We're here. We're here for you. We are your advocates. We are completely confidential. Even if you don't have the $10, we'll still see you. So call, make an appointment, and we're here.
All right. Thank our panel of experts for being here. Did you have something you wanted to add?
Oh, I was just going to say, well, thank you all for having me. I also wanted to just take a moment and thank all the organizations in our city who are doing the great work. I won't go through naming all of them because I'll get in trouble. But there are, there's some great things that are happening. I definitely even want to, just give a shout out even to Launchpad, which I think that we should be, giving more resources to Launchpad, because Launchpad is one of those organizations that fill in the gaps for our homeless youth here in our city. We need to be working more to make sure that our homeless youth here in our city, with our growing city, we want to be the it city, then we should make sure our homeless youth have those resources. So thank you to all the organizations doing the work. And my last thing that I'll say is, Nashville can't be the it city until all LGBTQ lives matter. Yes.
Very true. All right, thank you guys so much for joining us. We appreciate it. We got a lot of good questions, so thanks to everyone out there who is watching us. Hopefully we can do this again and get even more questions and make sure to keep the education out there. Thank you so much for watching. Have a great night.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.net.